So I think a big step here is actually taking a step backwards and realizing that there actually is treatment for substance use disorders and for addiction. Really, it took me going to medical school to first be exposed to the fact that people could get help for these things and that these helps could be effective. Treatment can be things like psychotherapy, group therapy, going and living in a new place where you learn about new ways to cope with life, and medications as well to help people with addiction.
Just like diabetes, for example, you think of a commitment to treatment would involve diet, exercise, medications, touching base with their doctor on a regular basis, perhaps getting physical exams, blood tests. It's not as simple as do this one thing and you are cured of your diabetes. Addiction is similar. Addiction treatment involves a variety of things. It involves medications. It involves psychosocial interventions. It involves going to meetings. It involves family support networks. It involves going to see your doctor, taking medications for other conditions that are related, such as other mental illness problems. So there's a variety of things that involve treatment for a substance use disorder. The most important thing would be that treatment needs to be individualized to the person. Treatment is a multimodal approach where not one size fits all for everybody. And treatment is a commitment to this over a longer period of time. That this 28-day model of I'm going to go to treatment and then I'll be cured and I will come home a new person really doesn't work. The 28 days might be the start of treatment where when they get out, that person then needs to commit to a continuum of treatment on an ongoing basis after the initial treatment in the hospital, much like with diabetes. A patient is admitted to the hospital, taken care of, they're stabilized, and then they're sent home. Well, guess what? Now they have a lot more treatment they have to continue to do: insulin, diet, exercise, check in with their doctor, et cetera.
So when you're looking at treatment models and how to go about addressing these treatments, then from a biological standpoint, we have medications that are available for addiction that have been evidence-based and useful. We have also social determinants and recommendations to include as part of your treatment program, such as attending peer support groups, mutual help groups, such as Alcoholics Anonymous and Narcotics Anonymous. There's a lot of data that supports using these programs to help. And then also from a psychological standpoint, there's a number of evidence-based psychotherapies that have demonstrated efficacy in helping somebody really work through and stay healthy through their addictions, such as cognitive behavioral therapy, motivational interviewing, contingency management. So there are a number of these, and the best treatments really try to incorporate all of these domains in helping one get better. How I usually refer to addiction and talking with many of those who are in the courts and probation officers, child protective services workers, whenever I have opportunity to share and educate, trying to help folks to understand that, listen, this is a chronic health problem. This is a chronic disease that manifests and is caused by three basic domains of the biologic, the social, and the psychological. And so what we want to be able to do is try to really appreciate the factors that have contributed in each of those domains, and then target our treatments to each of those domains as well. So using diabetes type 2 as a good example of a chronic disease, we know that from a biological standpoint, that there is an impairment in insulin secretion and also end organ insulin response that has a very strong genetic constitution of why somebody would be at risk for this. However, we also know that for those who grow up in a family, in a community where exercise is not well promoted, rather they live in a very sedentary lifestyle or culture, and where diet is also not something that's considered of great importance as well, that they are more likely and at risk to develop diabetes and have consequences due to that. And same thing from a psychological standpoint. We also know that during periods of heightened stress, anxiety, and depression, It affects the body's ability to truly secrete and process insulin and glucose metabolism. And this also creates problems with diabetes. So as an example of a chronic disease, and when you look at substance use disorder or addiction, we also know that from a genetic standpoint, there are strong genetic predispositions that puts one at risk for substance use disorder prior to any choices that they have made. And we also know that there are strong social factors that contribute to the development and manifestation of SUD as well. So if you live in a home where there is a lot of substance use, or you have a lot of peer groups where there is a lot of substance use and it's considered a normal thing to do, you're certainly more likely to engage in those activities. Also, if you live in a home where there is a high degree of abuse or trauma, that's also a big risk factor for developing addiction. And I'm sure many of you are aware of the high rates of correlation and association between adverse childhood experiences and development of many chronic diseases, including addiction. And then also psychologically, we know that if you are suffering from depression, anxiety, or other severe psychiatric disorders like PTSD or bipolar disorder, then you're certainly going to be more at risk to engaging in substances and progressing to unhealthy substance use to the point where it can be really negatively impacting your life. So when you're looking at treatment models and how to go about addressing these treatments, then from a biological standpoint, we have medications that are available for addiction that have been evidence-based and useful. How I describe the medications that are available for opioid use disorder to the lay public or to judges or to lawyers or probation officers or family members for that matter is I use the metaphor of doors, that our brain has a number of these doors that open to a certain degree for opioids. And if somebody has been using opioids such as heroin or pain pills long enough, they're used to having all of these doors wide open, and the chemicals are getting through that initially people were getting high from, and also helping them to feel better. And when those doors are shut, none of the chemicals are getting through. And that's when people go through withdrawal. That's when people crave, et cetera, et cetera. And so using that door metaphor, I'll talk about methadone is on the one end of the spectrum where those doors are wide open. And it's a full agonist medication. And it's letting in those chemicals to help satisfy the cravings, to help people get through withdrawal and maintain health and not being sick from withdrawal. And so we know that with methadone, it can help people sustain long-term sobriety because those cravings are under control and they're not getting sick. On the other end of the spectrum, we have naltrexone, which is a full opioid antagonist or an opioid blocker. And you could say that the doors are completely shut with the naltrexone. None of the chemicals are getting in. And this has been shown to help some with cravings, but also it will minimize the ability for somebody to get high if they were to use another opioid, because those doors are shut and it would be really hard to open with another substance. And in the middle of these two medications is buprenorphine. And buprenorphine is a partial opioid agonist. And what happens in this case is the door opens, but just opens partially. Some of the chemicals are getting through. Enough of the chemicals are getting through, so it's satisfying somebody's cravings. And it's also keeping somebody from getting going through withdrawal. One of the big advantages of this partial agonist is there is a ceiling effect to the experience that one can have with higher and higher doses. So it actually plateaus at higher doses and starts acting like a blocker at too high of a dose, and where it actually starts shutting those doors like naltrexone will if it's too high of a dose. This is very advantageous in the sense that it minimizes the likelihood of actually overdosing. It's very hard to overdose on buprenorphine. Most of the cases where we do see overdoses on buprenorphine is when there are other drugs in the system and other sedatives like alcohol. It's very clear that these medications save lives, and the mortality risk during and after MOUD. This was a study that was out a couple of years ago, a systematic review, meta-analysis, that for those treated with buprenorphine, that these medications helped reduce overdose mortality by 3 times and all-cause mortality by 2 times. We also see for medications such as methadone and buprenorphine that the medication use was associated with a 38% reduction in overdose and a 37% reduction in all-cause mortality based on another meta-analysis. And then a great study that came out last year in 2020 by Sarah Wakeman, which looked at over 40,000 people and compartmentalized whether they went into treatment, whether they got detox, whether they had intensive behavioral health services or buprenorphine or methadone, naltrexone or non-intensive behavioral health services. It was very clear from this study that there was a 76% reduction in overdoses at 3 months for those who were offered buprenorphine and methadone, and 60% at a year. Also, one of the important factors that we need to consider from a public health standpoint is the rate of infectious diseases that are associated with ongoing IV drug use. And so we do know that those folks who are offered medications for opioid use disorder, there is a decrease in the rate of HIV and hepatitis C, and also incidence of severe infections such as endocarditis or osteomyelitis subsequent to IV drug use. We have a huge and growing problem in Appalachia with rising levels of hepatitis C and HIV, especially over the last year and a half, that we need to pay close attention to and try to help resolve, or we are going to face an even greater crisis for years to come. So summary of the MOUD outcomes: treatment using agonist medication is estimated to reduce mortality by up to 50%. Treatment with methadone or buprenorphine is also associated with lower rates of other opioid use, improved social functioning, decreased injection drug use, better quality of life, and reduced levels of criminality. There is some evidence that compared with placebo, the extended release naltrexone, and naltrexone I didn't mention, but most of you are probably aware that naltrexone comes in both an oral form and a long-acting injectable form. The oral form has had historical problems with compliance, and the injectable form was an attempt, and a successful attempt, to improve the likelihood of compliance as far as just getting a once a month injection as opposed to just getting taking a medication every day. So is associated with reduced opioid use, but more rigorous studies are still needed.
So as a child psychiatrist who thinks a lot about trauma and treats a lot of patients and families who've experienced trauma, I think that is a missing piece of the conversation around addiction. Many people use drugs, not all of them become addicted, and we know that genetic predisposition is part of it, but we also know that trauma can predispose people as well. Part of our discussion in society around addiction really does need to include providing communities and families that are safe and stable and secure for children. We can build all the... And I will say that as a psychiatrist, as someone who works in this field, you have a front row seat to people's resilience and their ability to recover from life's challenges. And so I think the surprise for most people would be how inspiring this work can be, to see patients and families fight back and reclaim their lives and find a life after addiction has entered their lives.